Coming to the second part of my presentation on various reasons for failure in fixed partial denture and management. In this, we will be covering about the biomechanical failures now. Uh, Begin with mechanical failures. In mechanical failures, we have cement failure. Okay, now you know what is an ideal luting agent. Okay, in case of your porcelain fused to metal, in case of for your zirconia crown, the ideal luting agent should have three to four property. One, it should main properties apart from the regular properties. It should have the adequate working time. It should provide good seal. Okay, then it should have sufficient adequate strength properties. Okay, and it should have a proper working time and a setting time, so that uh, during the working time you can place the crowns in the patient's mouth, and then till it's completely seated. If you can see any excess cement is there, you can remove it. An inadequately cemented restoration, may cause an increased vertical dimension of occlusion, because, as you all know, when the crown is or the bridge is not seated, okay, definitely there will be an increase in the vertical dimension, or there will be a high point on that particular tooth. Then a loosening of the crown or fixed partial denture after a relatively short time, again because maximum pressure will be transferred on that particular abutment or the crown. Then once it is not completely seated, okay, what will happen? There will be an open margin, so from there will be a leakage and there will be a decay under the abutment. Okay, then when there will be an open margin, definitely it will lead to the sensitivity in that particular cervical end of the tooth. So causes of cement failure is, first you have to use the cement, okay, within the given duration as provided by the manufacturer. Especially this is true when you are using a resin cement, because the resin cement, once you open, okay, it is mentioned that you have to finish it in 3 to 4 months. So that is actually the expiry date of your resin cement. Like other cement, glass ionomer cement and all, they have mentioned the expiry, but especially in case when you are using a resin cement, once you open the cement, you have to finish it fast. Then prolonged mixing time, thin mix, uh, then cement setting prior to the seating, inadequate isolation, incomplete removal of temporary, so there will be inadequate bonding of your crown and bridge to the cement, thick cement space, okay, inclusion of any cotton fibers. These cotton fibers can be included if you have isolated the tooth, and during the cementation, some of the cotton fibers have come into the mix with the cement, and have been included in the restoration. Then insufficient pressure. Again, insufficient pressure, that means your process has not been completely seated. So, seeing this, these are the different type of the cement. Okay, so excess removal is easy. Okay, with your glass ionomer cement, but it is very difficult with your resin cement and your adhesive resin cement. So, one more thing is that the resin cements comes with different shades. So it is very difficult to identify where is your crown, where is your margin, and where is your adjacent tooth. So that has to be identified correctly, and then it has to be removed to prevent the cement failure. The strength, you can see the strength of glass ionomer cement is good enough to cement your porcelain fused to metal and your zirconia monolithic or a layered zirconia crown. And of course, for your Emax crown, you need to have your different luting agents. Then coming to the retention failure, okay, this is again also a very common cause. Okay, that is you have cemented the crown, you have cemented the bridge, it has come out. So what usually we do, first time we have cemented with the glass ionomer cement, next time we will cement it with modified glass ionomer cement. Even again it comes out, then we will use our resin cement. So before changing the cement, first you should diagnose what was the reason why why your restoration has dislodged, or why there is a failure occur. So you have to identify what is the cause. Okay, mainly the retention loss is due to your open margins, where there is the saliva has been constantly dissolving your cement. Okay, and if their retainer is loose, okay, one of the retainer is loose, if there is mobility of the abutment, all these things will lead to the failure of your mechanical failure of your bridge. That means your bridge is dislodged from the abutment. Okay. So these are the reason I have already discussed, like deformation of metal casting, technique of cementation, solubility of cementation, if any keyries have been there, mobility of one or more abutment. If there is a mobility of the abutment, what will happen? One of the your retainer will get dislodged, and there will be constant amount of the food accumulation in that retainer, and then there will be a looseness of the simultaneously the other retainer also become loose. Lack of full coverage, occlusal coverage. Okay, in cases where you have given a partial coverage retainer, insufficient retention of the abutment preparation, or poor fit of your castings. So what, how you can correct it? You can correct it with the following the proper uh, tooth preparation, that is your parallelism, the 10 to 12 degree should be maintained. In cases if the tooth length is less, okay, you can provide an additional retention features to the crown, that is providing the your grooves, okay, and your boxes, okay, or your extending the grooves from the buccal side to the occlusal surfaces, especially in cases where we give in the posterior, if you use short crown as an retainer, you have to give a groove extending buccally to the occlusal surface. So it prevent all the movements, okay, of your mm, retainer, and the crown will be more, will have more retention. So all these things, you all know this is a very simple procedure how to enhance the feature of retention in the crown or the bridge. So again, you can see what are the common cause of mechanical failure. You can see that as we have seen in the biological failure, the most common cause was the caries. Here, the most common cause is the loss of the retention. Okay, so that has to be taken care. Okay, then the connector failure. Okay, now the connector failure, you all know what is connector. It joins the retainer to the pontic, and the connector should have sufficient thickness. Okay, so that the it can withstand the forces. Now, sometimes it can fracture, maybe because the connector is thin, maybe because there is a casting defect, maybe because there is an internal porosity, maybe because there is improper buildup of the porcelain over the metal core structure, or if you have thinned the metal too much to build up to give a good aesthetic of a ceramic over the metal substructures. So these again are the reasons: incorrect casting techniques, overwork of the metal due to the length of the span or part that are too small, a failure to bond to the surface to the metal, and um the solder joint not sufficiently large for the condition in which it is placed. Treatment, again, if you remove all the factors which I have told, what are the causes, again it will it will prevent your dislodgements. Then the pontic failures. Now, pontic failure can especially occur in the anterior region, okay, where you have given the pontic, and then it is the size of the pontic is not same as to your adjacent abutment teeth. Okay, so the space which is present in the dentulous area, which is pontic space, have to be identified correctly. If any correction has to be done, orthodontic repositioning of the abutment can be done to improve the aesthetics. Residual ridge contour, many a times we see a large defects, okay, where if you are increasing the the bulk of the pontic or the material, more material of the pontic, what will happen? There will be more forces, there will be inflammation. So all these things can be avoided if you are using a in a case where there is a defect, like you all know Siebert classification, if the defect is more, you can go with a fixed removal type of the bridges in the anterior as well in the posterior region. Then biological consideration, okay, the pontic ridge contact. If the contacts are more, what will happen? There will be a constant inflammation of the gingival tissue. Okay, the patient will not be able to maintain the plaque removal program, and there will be a constant inflammation which will lead to the pocket formation adjacent to the pontic, that is with the abutment. So there are, as you all know, what type of pontic should be given. I'll not discuss this in detail because of the less time. You all know where the mucosal contact pontic should be given and non-mucosal contact should be given. Okay. This again will prevent your connector failure. How? Because in case where you have less space in the mandibular posterior region, you can use a modified sanitary where the connector of the pontic is increased, okay, to prevent the failure of the connector in that region. Now you can see this, okay. In this, the Pontic has been given in an area where the complete healing has not been taken place. So what will happen? There will be, once the healing has been taken place, there will be a large space, and if you have given, if you have given a modified ridge lap or a ridge lap type of Pontic here, there will be a constant accumulation of the foot. Once there will be an accumulation of the foot, what will happen? In turn, it will damage the adjacent area. Your uncovered abutment teeth where there will be a caries, root caries, and in return it will lead to the failure of your abutment, leading to the root caries, leading to your periapical pathology, leading to your apical bone loss. An occlusal wear has already been taken place. Okay, to prevent the occlusal wear, many a times we give a metal surface in the anterior region. Okay, where we see that many a times that constantly there is an wear of that region and the space is like in case of deep bite, we can give an occlusal surface with the metal. So to avoid any perforation, okay, what can be done? This also I'll not discuss because I already explained it. It has to be proper clearance should be given, okay, and adequate space should be given for the porcelain, for your metal substructure, okay, to prevent your failures. Tooth fracture, okay, this can occur where you have given a post and core, okay, where you don't have any much failure effect, and still you have given a post, a very good quality post, a very good quality material core, but since you have used this as an abutment, there are chances that because of the forces that this tooth might fracture. Okay. The feature, what are the fractures? Reason that can be trauma, can be recurrent caries. Okay. They're removing the processes intact with using a large forces. Then when you while removing the process, if you want to remove the processes and if you see any post and core is there, I recommend that you should cut the crown and then you can remove the prosthesis. Okay. This can be corrected, okay, by your post and core. But again, see in these cases, you can see, okay, these are the abutments, but these are the abutment. You can see this. This cannot be used as an abutment because there is hardly any tooth structure which is remaining. Even if you do any crown lengthening procedure or bone recountering again, so this is very long span. If it is single unit, at least you can think of that. But in these type of the cases, you cannot do post and core. You cannot do bridges. These tooth has to be extracted and then followed by some other definitive treatment plan. Root fracture, which is very rare, but sometimes it happens. Okay. Then porcelain fracture. This is also very common reasons. Okay, the failure of fixed partial denture, especially in cases if you are having a long span fixed partial denture and there is any chipping of the porcelain has been there, then it is very difficult. Okay, if everything is fine, then you can repair it with the help of an porcelain repair kits which are available. Condition the metal first, apply the bonding agent, apply the opaquer which is available with the kit, and then select the porcelain, select the composite shade with your natural porcelain, and then you can build up with the help of a composite. But again, it will not last long because the composite will keep on changing the color and you have to keep on polishing it. So if it is short span, better is to change the bridge, and before changing the bridge, you have to identify what was the cause of the failure. These are the treatment which I've already discussed. Okay. your porcelain repair kit can be used. Okay, you can clean it, you can apply bonding agent, and then you can, you can do a build up. These are again different type. It's given in the literature, hardly used nowadays because we don't use these type of bridges nowadays, and so hardly we do any type these type of repair nowadays. But since it is mentioned in the literature, I've just mentioned one slide about it. Then coming to the aesthetic failure. So aesthetic failure, you can see in the bridge which has been given here, all the aesthetic failure you can see here. First is that there is no shade matching because there is some staining, okay, discoloration of the staining and discoloration of the mandibular teeth, but the teeth which is given in the maxillary arch is of same shade. No attempt has been made, okay, to stain it. And if you see the embrasure area, okay, it has a black space. If you see the, margin at some places, it is open. So these are the aesthetic failure, especially in case when the patient is having a gummy smile, or if the patient is having a broad smiles area. What is a smile zone? When the patients smile, or the patient say E in exaggerated manner, the mesiobuccal side of first molar is seen from one side, to the mesiobuccal side of the premolar of the molar is seen on the other side. That is one thing that is called as, this is the extent. And if you see the vertical space, okay, as the age advances, more of the mandibular teeth are seen and less maxillary teeth are seen. So you have to identify the aesthetic zone, and then accordingly you can decide what type of the treatment, or what type of the buildup, or what type of the material you are going to use, okay, for the bridge. So color mismatch, as you can see in the figure, okay, there the shade is not matching with the adjacent teeth, okay. The shape is not matching. No attempt has been made to correct the your fracture adjacent teeth, okay. That's the reason more the existing restoration or existing bridge is noticeable. So these things has to be checked. Facing failure, again, I have explained, it also comes in aesthetic failure. Then these black lines, okay, so there are n number of reasons why this black line. Immediately, if you see these black line, it is because your impression is incorrect, your gingival retraction is incorrect, you have open margins, the technician has finished the metal framework, and then the margin is short there. Or if you see this in long duration, okay, there will be some amount of the gingival recession which has been taken place. So in the anterior region, okay, zero point 0.7 millimeter and 1 millimeter of the ceramic veneer space should be available, okay, to mask the metal substructures. Okay, this best masking is achieved with low transparency and medium opacity ceramic at 1.2 millimeter thickness. So these are the guidelines which has been mentioned, okay, for your metal ceramic restorations. Then design failure. Okay, you can see here that uh, with the help of two premolar, one molar has been given a cantilever, and this is the most common scenario seen in your day-to-day practice, where the dentist is not able to do implant or any other treatment plan. They just prepare two premolar and give one molar as an uh, Pontic. It is mainly seen in your private practice, not in the colleges. So for design failure, you have to see your what is your taper. As I already told, that correct taper should be maintained. That is 10 to 12 degree. Okay, definitive path of insertion. Then your correct marginal placement. So all these things, okay, will be taken at the time of abutment preparation. So adequate design can be given. Then your all external angles should be rounded off. If there is any sharp lines, what will happen? Okay, it will break during the time of your model boring, or there will be your wax will not go there, so you will have your bulkiness in that place when you try to block up with the help of your uh, spacer or something. Then there will be incomplete flow of the investment to the tax pattern. Then all these things, what will happen is that it will lead to the failure of your fixed partial denture. That's the reason we say that we have all rounded angles in your tooth preparations. Then inadequate bridge design. You can see here that so long bridge design here where there's a majorly tilted, and that's the reason this is completely failed. Cantilevers, bridges with too long span should be avoided. Okay, then fixed movable bridge with weak or inadequate abutment should be avoided. Okay, you can see in this figure. Then over prescribed bridges like using of more abutment or retainer, or overuse of retainers, that full crowns used when the partial crown or intra retainer would suffice, and then metal crown, ceramic crowns used instead of all metal crown where appropriate. So you can see now in this case, what has happened is that they have used an extra abutment here which was not required. Okay, the 3 unit bridge is an overuse of or over prescribed bridges. In this case, this crown, last crown, should be separate. And one more thing you can see here, for preventing the path of insertion, what the technician has done, that he has kept this margin open. Okay, so one thing is that the first thing is that this 4 unit combined, 1 unit has to be separate. If this unit has to be separate, the path of insertion could have been different, and this margin should have been placed exactly onto the tooth and not existing beyond the tooth, that is cantilever margin, or you can see that extension. So what will happen here? There will again the foot lodgement. Once there will be foot lodgement, there will be caries. There will be caries. So again, there will be foot lodgement inside the your abutment teeth, and this will become loose, and in turn, this might disturb the entire bridge, 4 unit bridge. So these things has to be taken care. Okay. Then inadequate clinical or laboratory technique. Okay, this is marginal deficiency. Okay, that excessive crown material beyond the margin, or you should have definite crown margin, tooth margin which is exposed. All these things, positive ledge, negative ledge. Positive ledge is overhanging, negative ledge is definite deficient crown margin. It has to be avoided to prevent the failures. So this can happen because of poor impression or unclear margin, improper dye ditching. So how it can be corrected? It can be corrected by making a new impression. So this is again the marginal discrepancy I've already discussed. Again, it is coming in this. So we'll skip this. Aesthetic problems already I have discussed. Poor investing in casting. Again, the lab has to take care properly while mixing the investment, proper mixing, vacuum mixing, no bubbles. Okay, proper water powder liquid, adequate casting procedure, proper casting machines. So again, these are the casting defects we will not discuss, but if there is any casting defect, in turn, it will lead to the failure of your fixed partial denture. Aesthetic failure, again, it will come in this category. Okay, already been discussed. Now, coming to the last part of my presentation is the failure in your zirconia bridges. So this is not given in any literature or book, because it is given only in articles, and with day-to-day practice, we see what are the failures. You can see this bridge which has been given here. Okay, that see the anatomy of the pontic and see the anatomy of the abutment teeth. So these both lateral incisors, central incisors are not matching, neither in height nor in width. If you can see the lateral incisor, see the lateral incisor. Okay, the shape of the lateral incisor on the right side is different, and the shape of the natural lateral incisor is different. You can see they have tried to match it with the help of a your gingival porcelain, but the gingival porcelain color is totally different. Okay, and it has to be masked. It has to be masked like this, so that the at least the length of the crown, length of the pontic is same as length of the retainer. So again, here also we see mechanical failure. There the mechanical failure is because of improper bonding of your zirconia material, zirconia layering porcelain, because zirconia layering porcelain is different, and your regularly metal layering porcelain is different. Zirconia layering porcelain has to be used when you are using zirconia copings. Then again, in cases of low temperature degradation, which is also called as LTD, is a transformation of your tetragonial zirconia to the monoclinic phase in moist environment at body temperature, leading to the surface roughening or microcracks and strength reduction. Veneer fracture, it is frequently complication with the layered zirconia. Clinical studies have reported the chipping rate is 10% more over 2 to 8 years due to occlusal load, thermal mismatch, and internal defects. So all these things lead to the chipping of your zirconia. Then there is connector failure also in these cases. Like we can see the connector of your fixed partial denture in anterior teeth. It should be 3 millimeter incisors cervically and 2 millimeter buccolingually. Okay. And increasing the gingival temperature and radius from zero point 0.6 to zero point 0.9 millimeter enhance the fracture strength. A 20% increase in fracture strength was observed. The connector is 3 by 3 millimeter dimension. So you have to take into consideration in anterior, if you there is a long span FPD or a short span FPD, the connector should be 3 millimeter by 3 millimeter on the interior and the posterior direction. So this is again the different type of design in 3 unit. In cases where there is an occlusal embrasure, you can see design 1 to design 4. uh, what is this here is that the thickness of the connector should be maintained in all the design. If you are giving the deep embrasure, try to compensate in the from the opposite direction. Minor chipping, again, it can be corrected by recountering it, and then this is very difficult to build it again. So the if the it is very minor, you can correct it, or if it is major, then you have to repeat your zirconia bridges. Then core fracture of the zirconia. This is also seen if you are using less quality of zirconia blocks. Okay, if you are using a blocks with a different sintering cycle, because every block has a definitive sintering cycle. In each block, there is mentioned that whatever sintering cycle you should follow. If you are not following the sintering cycle follow properly, there will be chances that there will be a core fracture. Technical failure, which lead to the weak zirconia framework due to porosity or incomplete crystal formation, poor marginal fit. Okay, again, because uh, if you have not designed the framework properly, okay, there the more easily the zirconia bridges fracture than your porcelain fused to metal. Okay, poor marginal fit, as you can see here in the first figure, poor marginal fit. Okay, there is an inflammation also. Okay, then definite marginal fit. Should you see the gingiva? There is no inflammation. Margins are closed. Biological failure is again a cementation failure. Like best cement to use zirconia bridge is your glass ionomer cement you can use, and you can use your resin modified or even a resin bonded cement in cases if you see that in the especially the crown length is little less. Periodontal abscess is seen in cases where you try to give subgingival finish line and you have not followed the biological width principle properly. So there will be inflammation, there will be formation of pocket. So these are the causes of your zirconia failure. What are the effects and how to prevent it? Okay. I'll discuss one or two here, like core fracture. It is because of the internal flaw, inadequate connector design, and fatigue loading. So effect is catastrophic restoration failure, proper connector design and proper designing of your fixed partial denture in exocad is required before sending it for the milling. And seeing that in cases where you need to have a more amount of the stresses are there, then it's better to use a monolithic zirconia. As you know that the layered zirconia have less strength as compared to a monolithic zirconia. So these all are the different reasons failure of the zirconia. Some even your implant zirconia crowns have been mentioned here. Design failure, as I've already told you, that you have to be proper in your design. You can see in this design that the margins are already short. So if the trained designer is not there to design your fixed partial denture, okay, because nowadays most of the labs have unqualified technician. They learn by themselves or they learn by YouTube and they start designing the fixed partial denture. So again, it can be because of the failure from dental side also, like inaccurate digital impression, Okay, that is your, if any saliva, blood, or a retraction cord is present in that, so the margins have been not improperly recorded in your digital impression. Stitching error or mismatching or missing data in full arch scan, then improper CAD designing, improper CAD milling, as I've told you. All the blocks have different sintering cycle, different milling protocols. Improper fit and marginal integrity is same as your porcelain fused to metal. Occlusional discrepancy is same as your porcelain fused to metal. So again, in case of your zirconia, you can see that the chipping is more common in CAD/CAM restoration, okay, followed by the secondary caries. So again, the failures are same here, okay, but here they have not done the study with the connector. Most of the bridges which are failing in case when you are using a zirconia bridge is a failure in connector also. Pain in FPD, this is again more common. These are the different forms, okay, which you have to identify it. Already discussed, I have given in chart form because if sometimes the question comes, you can mention this in short notes. That's the reason I mentioned, already discussed before. Laminate failure already last week, Dr. Vivek has taken this porcelain laminate and veneer. This also failed because of different reasons. You have to follow it properly. You have to follow all the protocols. So, what are the short answers which have been asked? Okay, these are the different questions like list the types of failure in fixed partial dentures. Okay, what is debonding of retainers in FPDs? So these are the different university papers which I was going through. So if you see every other year, there is some question which has been asked in failures in FPD. There sometimes there have been long answer and sometimes there have been an essay answer also which has been asked, okay, on these topics. So you can see here I have tried to cover most of the thing, but still because it's a very long topic, few things I feel that still can be read by the student from the books. Finally, to conclude, the successful RPD should include proper tooth preparation, a good quality of physical impression or digital impression if you are making a digital impression, proper cementation protocol, whether you are using cementing the zirconia crown or EMX crown or PFM crowns, and the maintenance phase. And before all these things, thorough diagnosis and treatment planning is required for the success of the fixed partial denture. Thank you so much.